You can teach me your game with no reason. Make me feel like a lonely friend. So call me now. Come on, babe.
Hello, Pharmative friends, and welcome to Pharmative Live on Facebook Live. This is Dr. James Partyka. I'm a clinical pharmacist and research scientist and the founder of Pharmative.com. So thank you for joining us. This is our opportunity to connect with all of you out there, to answer questions, respond to your text messages, and connect. So, as most of you may already know, this is Breast Cancer Awareness Month. So today we're going to review with you the results of a very large study that was recently published in the New England Journal of Medicine this past July. And hopefully you'll learn a few things about breast cancer along the way and how the treatment paradigm is constantly changing and changing at a very quick pace, which is good for everyone. It's good for the doctors, the nurses, the pharmacists, and the patients. And so with that, I'm of a firm belief that knowledge is power. And information is changing rapidly with all of the technology we have available literally at our fingertips. So with that, I'd like to review with you some data, some statistics, and again, this pivotal trial, which was just published by Sparano, if I said that correctly, and in the New England Journal of Medicine, and this is the reference number. And after the presentation, I'll make this information available both on Facebook and Pharmative.com. I'm going to start off with good news. The good news is that death from various cancers over the past 27 years have been decreasing by approximately 26%. And that's true for breast cancer, colon cancer, prostate cancer, as well as lung cancer. Now, the reduction in deaths attributed to lung cancer are dramatically decreasing, and that's probably due to a lot of people quitting smoking. So changing risky behavior that's associated with lung cancer. And you can do that by talking to your healthcare professionals about stopping to smoke. So that's all good news. Death rates from cancer is decreasing over the last 27 years. And it's because of breakthroughs in treatment, understanding the pathophysiology of the disease, as well as new emerging therapies like targeted therapies and immunotherapy. So the study that I'm going to review for you right now was a very large study in women diagnosed with breast cancer. So, as you recall, once someone is diagnosed with a tissue biopsy of breast cancer, generally speaking, they move towards surgery. And after surgery, the patient, the patient's family, and the healthcare providers discuss therapy options. This is referred to as adjuvant therapy. In other words, therapy when there's no signs of systemic disease. We've removed the tumor. We've dissected the lymph nodes, the axillary lymph nodes, and as far as we can tell, the cancer is gone. However, cancer is microscopic, and there may be disease that's hidden in different places within the body. And so that's why we give adjuvant therapy as a way of reducing your risk of reoccurrence of breast cancer. So that's what we're going to be talking about, a study which was done randomizing in a prospective cohort study women to receive either hormone therapy, which is less toxic, versus chemotherapy and hormone therapy. So in this prospective cohort trial of over 10,000 women with an intermediate risk score, okay, as defined as 11 to 25. Now let me explain this. commercially available is our ability to look at oncogenes. And there are various tests which are available, and those genes allow us to determine your level of risk of either developing cancer or reoccurrence or reemergence of your cancer. There are many different types of tests. I, as a healthy male adult, had recently done a 36 gene expression test to see if I have any oncogenes. So one of the key messages today is know your genes. That is, know through a blood test whether or not you are more susceptible to others. There's data that demonstrates that the BRCA gene, which you may all be very familiar with, the BRCA1 and BRCA2, that over 80% of women still do not know whether they carry that gene or not. So part of Breast Cancer Awareness Month is know your genes and ask your doctor whether you are a candidate for analyzing your genes and your risk, knowing your risk of developing cancer, or in this case, breast cancer. So this was a rather large study, and the study was conducted over 9 years. Women with breast cancer, generally speaking, from your biopsy of your cancer, we determine the hormone receptor status, the HER2 receptor status, and whether or not your lymph nodes are positive for breast cancer. Those are 3 major determinants of your risk of reoccurrence of your breast cancer. Hormone receptor status can determine whether you're a candidate for hormone therapy. HER2 negative is going to determine, or HER2 positive, whether or not you're a candidate for HER2 therapy. And your lymph node status is basically a marker of whether or not you have systemic disease or not. So in this particular study, we're looking at hormone receptor positive women, HER2 negative, and lymph node negative women. The gene assay is available commercially. That's good news. This is available to all people right now through a company named Genomic Health. Oncotype test. That's the test that they used in this particular study. The endpoint was invasive disease-free survival, which is a marker, again, of reoccurrence, of relapse of the breast cancer disease. And in this particular study, over 6,700 women had an intermediate risk score of between 11 to 25. So if you have a low score, generally speaking, you're not a candidate for chemotherapy. If you have a high score above 25, you are a candidate. But those women that fall in between, we're kind of not sure if chemotherapy will benefit that particular patient or not, or on average. And so that's what this study was trying to decide. So when we randomized the women with an intermediate risk score of 11 to 25, they were either randomized to hormone therapy alone versus it's chemotherapy plus hormone therapy in the other arm. In this particular study, the primary endpoint, as I mentioned earlier, was disease-free survival. This was a non-inferiority trial, which means we're asking the question, are these 2 different treatment arms about the same? That's a non-inferiority trial. And in this particular case, there was no difference between hormone therapy alone, which has less side effects, much less side effects, than chemotherapy and a hormonal therapy. And that was 83.3% versus 84.3%. So no difference in invasive disease-free survival. The second endpoint was overall survival. Are the patients alive? So at the end of 9 years, you can see there was no difference. 93.9% were alive on the hormone-treated therapy versus 93.8% on the hormone and chemotherapy trial. So this is clearly defining a patient population of women that don't need to receive chemotherapy If they have hormone receptor positive disease, HER2 negative, lymph node negative, and if they have an intermediate score by the Oncotype test, then discuss it with your physician, your oncologist, your nurse, your pharmacist. Do I need chemotherapy? And possibly you don't, and you can avoid all of the side effects associated with conventional chemotherapy. So this is really breakthrough data which is emerging, and the treatment paradigm is shifting for these women with these particular characteristics. Now, one final point on this study, which was published in July in the New England Journal of Medicine, is that women that were less than 50 years of age, some of them may benefit from chemotherapy. So younger women could possibly benefit more than older women. So again, something to discuss with your oncologist. And that's it for today. I want to thank you for joining us. Remember, stay healthy, and I'll see you next week.
You can teach me you're gay with no reason. Make me feel like a lonely friend. So call me now. Come on, babe.